Hello everyone once again. So we will be discussing, as per we decided, we will be discussing 25 MCQs. So how many of you are there? 5 are there at least. So we can start with it. So the first question is, what we have here is, that is the activation energy is the free energy difference between what? So basically the options here are substrate and the product, substrate and the transition state and the product, or some of the all the above. So I'll repeat the question. What is the activation energy? So it is a biochem question. So activation energy is the free energy, and the difference between them is what? The options are substrate and the product, substrate and the transition state and the product, and sum of all the above. So basically what we have to know here is what is the activation energy. So activation energy, what we know is, if you have to start any process, you need that much energy for the substrate to become the reaction. So the answer here is, if anyone wants to guess, you have to remember this question. So the answer here is, activation energy is the free energy difference between substrate and the transition state. So this we have to remember. See, the enzyme increases the rate of reaction by reducing the activation energy. That's it. Okay, next question we have. Which of the following methods is used for a delivery of the after coming head in breach? Burn-Marshall's method, Malesius-Millesvit method, Piper's forceps, or Killian's forceps? I'll repeat the question once. Which of the following methods is not used? You have to not use for a delivery of after coming head in breach? Burns-Marshall method, Malesius-Millesvit method, Piper's forceps, or Killian's forceps? So anyone, if you want to answer? So which of the following method is not used for a delivery of the after coming head in breach? Burns-Marshall, Malesius-Millesvit, Piper's forceps, or Killian's forceps? So we have to rule them out. Basically Burns-Marshall and all that we use here, but which is not used here is the Killian's forceps. Why? That's the main thing. That see, for delivery of the head we use Burns-Marshall, Martin's and Piper's forceps, and Wizard Martin. If it is an extended leg, then fourth is the answer. So if it is an extended leg, we use Pinard's manual. If it is an extended arm, we use Lobster's manual. And if it is a chin to pubis, we use Prague manual. So basically there is a mnemonic which they have given here is the extend arm to express love, that is Lobster's. And for Pinards, it is put the fingers in the popliteal fossa for Pinards, for P for P, like that. But the answer here is, which of them is not, it is Killian's forceps. Next question we have, which of the following statement about the femoral hernia is true? First, it occurs exclusively in females. Second, all femoral hernias should be repaired. And third, it does not strangulate. Fourth, femoral vein lies medial to the sac. So which of the following statement about this femoral hernia is true? It is exclusively in females. It should be repaired. It does not strangulate, or it is femoral vein lies medial to the sac. So which one is true among this? Okay, see, all the options here. Basically, see, exclusively in females it is not like that. Option A, if you want to see it, is like femoral hernia occurs in both males and females, so you cannot tell it is only in females. Option C is does not strangulate. The incidence of strangulation for femoral hernia is very high, so you have to rule out that option also. Then option D is femoral vein lies medial to the sac. No, it lies lateral to the sac. Let's say anatomy, that we have to remember this. That is, in the femoral canal it happens. So the correct answer here is all femoral hernias should be repaired. Yeah, that's true, because you can see the Insta is also present in this. So it has to be repaired. So they have given here is all the femoral hernias should be repaired, and the in selected femoral hernias should have the hernial sac content examined for the viability. So it should be repaired. So then next question we have, a patient was found to have tumor extending up to 1 centimeter below the gastroesophageal junction on EUS. According to the Severs classification, which stage of carcinoma does she have? Type 1, type 2, type 3 and type 4. So which one the classification she is having? Look at that. I will repeat, a patient was found to have a tumor extending up to 1 centimeter below the gastroesophageal junction on EUS. According to the Severs classification, which stage of carcinoma does she have? Type 1, 2, 3 or 4. See, the classification you have to remember here. So the answer here is, anyone wish to tell the answer? Okay, the answer here is, it is type 2. Now for that you need to know the type 3 is not the answer, See, the question is 1 centimeter below the gastroesophageal junction. But for type 3, what you are saying, it should be located between the 2 to 5 centimeter distal to the anatomical cardia, that is the junction only. So it is 2 to 5 centimeter, then it is type 3. And if it is between 1 to 2, it is type 2. And if it is located between 5 to 1, that is 5 to 1 proximal, that is above. 5 to 1 is type 1, 1 to 2 and 2 to 5. And that is the Stewart's classification for adenocarcinomas of the esophageal gastric junction. Next question we have, in a study on hemoglobin levels in a healthy woman, data recorded was a mean of 13.5 gram per dl and the standard deviation of 1.5 gram per dl. So what is the Z score for an element with a hemoglobin of 15 gram per dl? I will repeat the question once. See, if you are doing a study on a hemoglobin levels in a healthy woman, and the data you got, the mean level was 13.5 gram per dl and the standard deviation is 1.5 gram per dl. So what is the Z score for an element with hemoglobin value of 15 gram per dl? Basically it's a PSM question again. So then what is the Z score? So the options are 1.5, 10, 2 or 1. This for Z score you need to know the formula. So if anyone wants to answer this, you can try it out if you know the formula basically. Without formula, you won't be able to tell this. I will wait if anyone wants to tell the answer. Okay, the answer here is 1. How it is, I will tell. See, Z score of it is for 15 gram per dl is 1. The formula here. The formula is Z is equal to H minus mu by delta. Now, okay, H is the value of the element, mu is the mean, and delta is the standard deviation. So as per the formula, it is like 15, they have given 15 minus 13.5, that is the mean, divided by 1.5 standard deviation. So here Z score is equal to 1. But okay, Z score we remember like the formula, but what is Z score? See, it indicates the position of any element in a distribution in terms of how many standard deviation it lies from the mean of the distribution. I know you didn't get it, but yeah, no need to get it also. PSM questions, you just have to need to know the formulas. So Z score is H, that is the value, that is real value what is recorded, minus the mu, that is standard deviation by standard deviation. So yeah, then next question we have, the following finding is not typically seen in which of the following condition? So basically they have given a pathological image. Okay, I will tell you, I will give the hint. The hint here is, there is a peripheral smear which they have shown, and it shows a teardrop cells. Teardrop cells, or you can say dacrocytes. Okay, so which of the is not typically seen in? The options are myelodysplasia, myelofibrosis, thalassemia or sideroblastic anemia. So the question what here is, which of the teardrop cells is not seen in myelodysplasia, myelofibrosis, thalassemia, sideroblastic anemia? See, teardrop cell is cannot show you by the image. You can search it later what is teardrop cells. So yeah, it is seen in which of the condition you have to remember, and you will rule out the options like that only. So the options are myelofibrosis, basically I am telling you what are the conditions in which teardrop cells will be seen. That is myelofibrosis, myelodysplastic syndromes, hemolytic anemia, thalassemia, and severe iron deficiency. So by the question it is sideroblastic anemia doesn't have a teardrop cells. So in this you have to remember. I will again repeat. It is myelofibrosis, myelodysplastic syndrome, hemolytic anemia, thalassemia, severe iron deficiency will show teardrop cells. Next question, we have a 50-year-old man is there who is referred for evaluation of severe anemia. So okay, it is high in severe anemia, persistent fever, recurrent epistaxis, and the lab investigation they have given. So what is the diagnosis? So lab investigation is hemoglobin is 6, total WBC is 40,000, platelet is 12,000, bone marrow is 10% blast. It is significant actually. 10% blast positive for T8,21 translocation. So what is the condition diagnosis? ALL, AML, pre-leukemia, leukemic leukemia. This you can just tell by seeing the bone marrow only. 10% blast cell is seen in which condition? AML, ALL or pre-leukemia or aleukatic leukemia. If anyone wants to give the answer, if okay, I will tell here. See, 10% blast cell will always be seen in AML. AML there is WBC criteria which we have to fulfill. So it is like, see, if it is a blast cell count is greater than 20% in either peripheral smear or bone marrow, and then it is less than 20% in the presence of any one of the following, that is T1517, T821, and inversion of 6:16. So basically the question said that bone marrow had 10% blast cells, and that too it is positive for 8:21. So as per WBC classification, it is for sure it is AML only. If it is more than 20%, it is AML. If it is less than 20%, we have to see the criteria, that is it is T,821 or T15,17. So next question we have that is the image they have shown here. The image shown below the technique of insertion in. Okay, that I cannot describe because the image I cannot show here. So basically it's that is a laropharyngeal mask airway. You might know there is one cup which is used to insert here in laryngopharyngeal mask. So I cannot show you the image, but yeah. So next question we have. See, during a boxing match, a young adult was punched in the left eye. Immediately after the trauma, he noticed black spots, stains, and cobwebs drifting about while moving his left eye. It was also associated with diffuse blurring of vision, and his ophthalmology was suspecting that it is a vitreous hemorrhage. So, what is the investigation of choice? I will repeat the question once again. During a boxing match, a young adult was punched in his left eye. So, immediately after that, he noticed black spots, stains, and cobwebs drifting about while moving his left eye. While moving, he was not able to see basically, and it was associated with blurring of vision. So now his ophthalmologist suggests that it is a vitreous hemorrhage. So what is the investigation of choice? ERG, USG scan, USGB scan, or optical coherence tomography? So anyone, if you can answer, it is an ophthalmology question. Investigation of choice in vitreous hemorrhage. All that was okay. Just they are asking what is the investigation of choice in vitreous hemorrhage. ERG, USG scan, USGB scan, optical coherence tomography. So anyone, if you want to answer this, you can go ahead. Okay. The answer here is USGB scan. Well, it is the investigation of choice in vitreous hemorrhage. Now, see, what are the causes of vitreous hemorrhage? You all know that it is like trauma is there, retinopathy is there, diabetic and all, retinal vein occlusion, sickle cell disease. Mainly to be with that associated with retinal tear avulsion, that is trauma, diabetic retinal vein occlusion, sickle cell disease, vasculitis, and systemic like we have bleeding disorders. So yeah, so it is a USG-B scan is the investigation of choice for the vitreous hemorrhage. Okay, next question we have. So which of the following is not included in the blood supply of putamen? So the options are medial straight artery, lateral straight artery, anterior caudal artery, posterior communicating artery. So the question is which of the following is not included in the blood supply of putamen? Medial straight artery, lateral straight artery, anterior caudal artery, posterior communicating artery. So you should know the anatomy for this. So anyone see what is putamen? First you need to know that. Basically, within the basal ganglia, one structure is there called putamen. So they are asking which is not the blood supply of putamen. So if you don't know the anatomy, I don't think you will be able to do this. So okay, and I will tell the answer here. The answer here is posterior communicating artery does not supply the putamen. So what all? Yeah, fourth is the right answer. So what all supplies is medial straight artery, lateral straight artery, and anterior caudal artery. So if your anatomy is strong, then only you can answer this. Otherwise, okay. Next question: which drug, when given to a mother in a third trimester of pregnancy, would result in the following findings in her newborn? Again, it's an image-based question, but okay, I will tell that. Okay, I will just tell what is the condition. The condition is it's a floppy baby syndrome. Okay. So, which drug, when given to a mother in the third trimester of pregnancy, would result in a floppy baby syndrome? The options are venlafaxine, diazepam, promethazine, or clozapine. So basically, you should know what is a floppy baby syndrome and which drug will cause this. So the options are venlafaxine, diazepam, promethazine, and clozapine. So if anyone wants to answer this. Yeah, I have the picture between normal baby and floppy baby is like you can put, okay, I'll let it be. Well, the answer here is diazepam because benzodiazepine will cause floppy baby syndrome. So others will not cause floppy baby syndrome. And what are the anomalies? Yeah, diazepam is the right answer. So what are the anomalies associated with the floppy baby syndrome? That is, again, okay, let it be, image is there. See, if you give a benzodiazepine in pregnancy, what will happen? So if you give it in first trimester, it will cause cleft palate and GI anomalies. And if you give in third trimester, yeah, it will cause floppy baby syndrome with neonatal hypotonia as a withdrawal effect. And one more thing is that the fetal lithium exposure is also associated with floppy baby syndrome. So you got it, I think. It is benzodiazepine. That too, if you give it in third trimester, then only it will cause floppy baby. Otherwise, first trimester, cleft palate and GI anomalies. So next question we have, organism is there which has been cultured in a bonded genuine medium. Shows smooth refracted glycerin colonies resembling bisected pearl or mercury drops. The organism is most likely. It is options are Bordetella parapertussis, Bordetella bronchoseptica, Bordetella pertussis, and Bordetella petri. So you should know, it's a microbiology question, you should know what is first bonded genuine medium and what are its source. I will repeat the question again. See, you are given a culture in a bonded genuine medium with so smooth refractile glycerin colonies resembling a bisected pearls or mercury drops. Options are Bordetella parapertussis, Bordetella bronchoseptica, Bordetella pertussis, and Bordetella petri. Okay, anyone? Let's answer this. See here, only the thing which you have to remember is bisected pearls and mercury drops are seen in which condition. That's all. Other all that incubation, all that is not required here. So the answer here is yeah, Bordetella pertussis is the answer. So you have to remember that in bonded genuine medium, bisected pearl or mercury drops. That is Bordetella pertussis. Next we have that is leukoerythroblastosis is one of the diagnostic criteria for which of the myeloproliferative disorders? The options are CML, polycythemia vera, primary myelofibrosis, and essential thrombocythemia. So, hello. So yeah, the question is leukoerythroblastosis is one of the diagnostic criteria for which of the myeloproliferative disorder. That is, the options are CML, polycythemia vera, primary myelofibrosis, and essential thrombocythemia. So anyone wants to answer this question? Leukoerythroblastosis. Okay, first let me tell you what is leukoerythroblastosis. It is an abnormal peripheral blood smear in which it shows premature release of nucleoid erythroid and early granulocyte progenitor due to marrow distortion. So basically, it's not a normal condition. It is that the progenitors of the normal bone marrow will be present here. So the answer here is for diagnostic criteria for leukoerythroblastosis. The answer here is primary myelofibrosis. That is, leukoerythroblastosis is one of the minor criteria for diagnosis primary myelofibrosis. So now we have I will tell you in which condition leukoerythroblastosis can be seen. As in it is seen in metastatic cancer, granulomatous disorders, Gaucher disease, and a spent phase of polycythemia vera. So next question we move on. Extracellular concentration of a negative ion with valency is 1 is 10 millimole per liter, and this intracellular concentration is 100 millimole per liter. So you know the formula here. So yeah, the question is the equilibrium potential for this ion using the Nernst equation is dash, that is 10, minus 10, 60 and minus 60. So what is Nernst equation? You have to know, otherwise you won't be able to answer this question. So it's a biochem question. See, biochem questions mostly it's like that only, you have to remember and mug up. So here the answer is, if anyone wants to tell, the options are, I will again tell it is, 10 millimole per liter is the extracellular concentration of a negative ion, and the intercellular concentration is 100 millimole per liter. Anyone? I don't know why this question they have given, but I don't know it will come also, because the formula is like that. Formula is EMF is equal to 61 by Z into log concentration on one side by concentration on the other side. So how will you do log in your exams? It's a waste question. Okay, next question we have. A 30-year-old patient comes to you who is drowsy, and he was brought to the casualty. Pulse is 130 per minute, respiratory rate is 30 per minute. Blood gas analysis was done, so it shows metabolic acidosis is present, and hypocalcemia is there. Blood urea is 100 mg per dl. Creatinine is also high, that is 3.4 mg per dl. So you do a urine analysis, so it shows calcium oxalate crystals. Then he showed improvement on nasogastric aspiration and administration of sodium bicarbonate, calcium gluconate, and 4-methyl pyrazole. So which substance did he most likely consume? Formaldehyde, ethylene glycol, paraldehyde, methyl alcohol. Question is only very big. See, again I will repeat, it is a 30-year-old patient who is a male patient, drowsy, and he comes to the casualty with pulse is 130 and respiratory rate is 30. He has metabolic acidosis, hypocalcemia, blood urea is 100 mg per dl, creatinine is 3.4, and if we did a urine analysis, it shows calcium oxalate crystals. And he showed improvement on nasogastric aspiration and administration of sodium bicarbonate, calcium gluconate, and 4-methyl pyrazole. So which substance did he consume? Likely to be consumed. Formaldehyde, ethylene glycol, paraldehyde, or methyl alcohol. So anyone, if you can answer this. Okay, the answer here is ethylene glycol. See how I will tell you. The patient, all the is whatever we got to know, history of consumption is there, drowsiness is there, tachycardia is there, tachypnea is there, and all that metabolic acidosis is there, acute kidney injury, that is acute injury because there is elevation of ethylene glycol is the answer, and hypocalcemia. Basically, it is precipitation of calcium oxalate crystals, and whatever I told actually. See, all these features particularly including the presence of kidney damage, that is, it points towards ethylene glycol poisoning. And see, methyl alcohol poisoning and ethylene glycol poisoning both can be present in the same way. So the key distinguishing feature between a methyl alcohol poisoning and this is the presence of eye symptoms. So if there is presence of eye symptoms, you cannot say it is ethylene glycol. It will be ethylene glycol poisoning. So you have to differentiate in that way. So if it is eye symptom, that is blurring of vision, loss of vision due to retinal damage and all that, then you can say it is a methyl alcohol poisoning. Otherwise, it is a ethyl alcohol poisoning. Hope it is clear. So next question we have. 57-year-old woman comes to you with a chest pain and was diagnosed with MI. Then what test can be detected? What test can detect areas of reversible MI in this patient? So the options here are coronary angiography, Muga scan, thallium scan, or resting echocardiography. So a 57-year-old patient comes to you with MI, and you have to just tell which test will detect the reversible MI in that patient. Coronary angiography, Muga scan, thallium scan, or resting echocardiography. See, angiography, angiography won't detect, and angiography won't detect only anything. In case of MI, if only it is a blockage that can be detected, but reversible areas it won't detect. Muga scan also. Muga is basically it is a nuclear medicine test that can evaluate the function of ventricles. 4 and 3. 3 is the right answer. That is a thallium scan. See, Muga is like it will evaluate the function of ventricles and not required there. Thallium scan, yeah, it is performed for reversible. In this procedure, basically the imparts are appeared as a cold spots. So it is not arrest and okay, and resting echocardiography is also it won't detect any reversible. So you have to remember this thallium scan will detect the reversible changes that is it happens in the MI. So next question we have a patient comes to you with a fever of 1 week, history of 1 week with abdominal distension, loss of appetite and lymphadenopathy. There is poor response to antibiotics and antimalarials. The viral test is negative, but RK39 is positive. Which drug can be used in the treatment of this patient? So if it is a fever, abdominal distension, loss of appetite, lymphadenopathy, and no response to antimalarial or antibiotics, and viral test is negative, but RK39 is positive. So now what you will give to the patient? It is the options are liposomal amphotericin B, fluconazole, linezolid, or bedaquiline. So it is basically they are suspecting what they are suspecting. See, it is not bacterial or it is not malaria also. So RK39 is positive, that is a clue which you have to think here. And the options also, see, amphotericin B and all that, it is given in fungal infection. Fluconazole, linezolid, bedaquiline. Fluconazole is not the right answer. It is not the right answer. So yeah, the right answer here is basically first one, that is the liposomal amphotericin B. But the diagnosis, what we have to know here is, from diagnosis is Leishmania donovani. How did it did? Yeah, amphotericin is right. How did it did? See, it is diagnosed by ELISA, indirect immunofluorescent acid test, and RK39, which detects antibodies to Leishmania donovani. Yeah, answer is liposomal amphotericin only. So you have to remember, if it is RK39 positive, it goes towards Leishmania and it is managed by liposomal amphotericin B. So other options like fluconazole and all that, Linezolid is used in the treatment of MRSA. Bedaquiline, it is a newer anti-TB drug. And fluconazole also is the antifungal, but it will not be present, not be useful in leishmanias. So leishmaniasis, liposomal amphotericin B. Next we have the elimination after 3 half-lives in first order kinetics is 12.5%, 75%, 87.5%, 94%. Okay, so elimination after 3 half-life in our first order kinetics is 12.5%, 75%, 87.5% or 94%. This basically you have to remember this because we have learned it like here. First half life it is 50% it will go, second half life, third half life, like that. So the answer here is 87.5. See, in first half life we all know that 50% will go away, but second, third and fourth we have to remember. In second it is 75% will be eliminated. In third, which is the question, it is 87.5% it is eliminated, and the 4 half life it is 93%. So like that 50, 75, 87.5 and 93%. Next question, what is the most appropriate treatment for a patient with severe digoxin toxicity? The options are potassium supplements, propafenol, quinidine, Fab segment of digoxin antibodies. So which is the most appropriate treatment for a patient with severe digoxin toxicity? Potassium supplements, propafenol, quinidine, or Fab fragments of digoxin antibodies. So in digoxin you have to remember which of the drug is used. Digivand. Yeah. The answer here is the Fab fragments of digoxin antibodies. That is a digivand only, in short you can tell that. So it is a purified Fab fragment of digitalis antibodies. It neutralizes the digoxin action and its doses is okay. Other points are not indicated, and quinidine and propafenol are not indicated in arrhythmias caused by digoxin, and KCL is indicated only in mild toxicity as hyperkalemia. Okay, basically investigation of choice, treatment of choice here is Fab fragment of digoxin antibodies. It is the appropriate treatment here. Next question, we have a full-term infant with a history of polyhydramnios in utero, presents with a respiratory distress soon after the birth. So on examination, frothing of the mouth is observed. So what will be the immediate investigation of choice? The options are chest radiography, lateral neck radiography, passing a nasogastric tube with subsequent chest radiography, or an erect X-ray abdomen. So it's a case of polyhydramnia and respiratory distress is there after birth, and you observe there is a frothing in the mouth. So what will be first investigation of choice? Immediate chest radiography, lateral neck radiography, passing a nasogastric tube with subsequent chest radiography, erect X-ray abdomen. Anyone wants to answer this? See, frothing of the mouth will be the C. Yeah, C is the right answer. See, it is this polyhydramnia is risk factor, and respiratory distress also. See, the basic condition is simply frothing of the mouth. So at first you investigate and okay, but at first you have to remove that. So when you put an nasogastric tube and you check for it, and what you will get, there will be some obstruction like that, because it is a TF. TF is most commonly seen with polyhydramnias and with respiratory distress. So TF, usually it's a transesophageal, it's a fistula. So you have to get with that, passing an nasogastric tube with a subsequent chest radiograph. So you will check it is a esophageal atresia with TF. Yeah, C is the answer. So this can be confirmed by chest X-ray and all that. It will be coiling of the nasogastric tube, because if it is atresia, it won't go only. So as shown in the image, okay. early onset respiratory distress for your mouth and history of polyhydramnios. These things you have to remember in that. Okay, next question. The modified Rodnan skin score is used to assess the severity of skin involvement in which of the following condition? The options are dermatomyositis, systemic sclerosis, MITS, connective tissue disorder, SLE. So I repeat, the modified Rodnan skin score is used to assess the severity of skin involvement in which of the following conditions? Dermatomyositis, systemic sclerosis, MITS, connective tissue disorder, or SLE. You have to remember what is first Rodnan skin score, otherwise you won't be able to tell. So anyone want to tell the answer? Rodnan skin score is used for the severity of the skin involvement in which of the conditions? B, yeah, B is the right answer. Systemic sclerosis. The extent of skin sclerosis and systemic sclerosis can be measured most commonly by this modified Rodnan skin score. Basically, systemic sclerosis, what will happen is your skin, well, the skin will get thickened, thickness will be increased. So here the scoring of each region is determined by the skin thickness. Yeah, it is scoring and then on that. So other methods, how will you monitor the skin thickness? First is this Rodnan skin score is okay. Other methods is durometry, 20 MHz ultrasonography, and optical coherence tomography. So by this you will able to monitor the skin thickness. So next question we have, a 25-year-old woman comes to you with palpitation. She informs you that a urine pregnancy test done 1 week ago was positive. Her investigation reveals hyperthyroidism. So which of the following antithyroid drugs can be prescribed for her? So the patient is 25-year-old with palpitation and she informs you that she is UPT positive 1 week ago only, and you have hypothyroidism is present. Which of the following antithyroid drug can be prescribed for her? Propylthiouracil, methimazole, carbimazole, propranolol. So basically they are telling which is the drug you can give in pregnancy for a patient with hypothyroidism. This you have to remember. So the options are propylthiouracil, methimazole, carbimazole, propranolol. So at least you should answer this. Anyone? It doesn't have a teratogenic effect. PTU, yes, PTU is the right answer, because others like carbimazepine and all that, we have teratogenic effects will be there. So the patient with this clinical scenario in the first trimester, it is in first trimester, and you can give propylthiouracil because of lower teratogenic effect. See, if it is the first trimester, you have to give propyl this only, and if it is second trimester, you can give carbimazole. You cannot give propyl. So you have to remember which trimester it is. And then next question, what is the distance between promontory and tympanic membrane? So this is options are 6 mm, 4 mm, 2 mm, or 1 mm. Distance between promontory and tympanic, yeah, first trimester it is PTU. So distance between promontory and tympanic membrane, 6 mm, 4 mm, 2 mm, or 1 mm. Yeah, that's what I said. It is carbimazole for second and third trimester, and then methimazole. Yeah. So yeah, the question is what is the distance between the promontory and the tympanic membrane? The options are 6 mm, 4 mm, 2 mm, and 1 mm. So this is a ENT question, and you have to know the anatomy in this. So if you know the distance, then only 6 mm. No, 6 mm is actually very big. The promontory and tympanic membrane are very close together. Okay, the answer here is 2 mm. And the distance between the promontory and tympanic membrane, that is the transverse diameter at the level of mesotympanic, is 2 mm. No, it is not said 2 mm. Okay, next question we have, a teenager is there who has an injury in his middle finger while attempting to catch a basketball during a match. On examination, his finger appeared as shown below. So which of the following is false regarding this condition? The options are: extensor tendon is disrupted at the distal interphalangeal joint, results from a forced extension of fingertip, passive extension of distal interphalangeal joint is preserved, and dorsal hyper extension splints are used into treatment. So basically, see what happens. I will tell you. See, in the middle finger, you got an injury, and while playing basketball, basketball only, and it is shown below. What is the following of false? Because the image is like this. See, the image what they have shown is like this. This is like this only. So what is the false statement here? The extensor tendon is disrupted at the distal interphalangeal joint, results from a forced extension of the fingertip, passive extension of the distal DIP joint is preserved, and dorsal hyperextension splits are used in the treatment. So basically, you have to know what is this condition known as. I have already given a post before. I have given in the page also this condition photo I have given. So you can tell. First thing, what is the condition? Then only if you can tell. It is a force flexion on the fingertip and cause this. Okay, I think no one knows. Okay, it's a mallet finger. What happens? See, the extensor tendon is here, or the extensor tendon will attach here. So basically, there is a disruption. The tendon will it will disrupt here, so it won't be able to move this hand. So it will like this. It will remain like this only. So they have given eversion injury. Eversion injury is there of the extensor tendon and the DIP joint. So it is a mallet finger. My condition of mallet finger. So the false here is results from a forced extension of the fingertip. No, the answer it will result from the forced flexion. If you flex, then only it will be disrupting. So extension won't cause any disruption in this distal interphalangeal joint. And the other is the extensor tendon is disrupted at the distal interphalangeal joint. That is right. Passive extension of the distal interphalangeal joint is preserved, because the problem is it caused by the flexion. So passively can do, but actively cannot do. Then dorsal hyperextension splints are used. Splints are used for the treatment of the mallet finger. Okay, one last question is there. After that, it will be over. The last question, it's a OBG question. The first maneuver for shoulder dystocia consists of forceful adduction by extension of leg on abdomen, forceful adduction by flexion on legs on abdomen, forceful adduction of legs by extending them on abdomen, or forceful adduction of legs by flexing them on abdomen. Okay, I think you won't be understanding this. Just tell me in shoulder dystocia which maneuver we use, the name of the maneuver. That's enough. If you know the name of the maneuver, you will be able to tell what all answer it will be. Anyone can tell the name of the maneuver? The maneuver which is used in shoulder dystocia. Okay, the answer here is forceful abduction of leg by flexing them on abdomen. And the maneuver what is used is the McRoberts maneuver. That is, we will do a flexion and abduction of the maternal hips, positioning the maternal thighs on the abdomen, so that the dystocia which is there can be, basically the fetus can easily come out by this. So remember this, it is a McRoberts maneuver for shoulder dystocia. And by this we get to the end of this 25 MCQ. So thank you so much, and take care. Bye. Good night.